we have somatic senses and special senses, right? Special senses are those that we have some specified organs for them, like vision, hearing, smell, taste, and equilibrium. We have a special organ for them. But the somatic senses are those that we don't have in a special organ. The receptors are spread all over the body, in the skin, muscle, bone, joints, everywhere in the body. Okay? So, the classification for somatic senses is like this. We have mechanoreceptive senses. So the stimulus in this type of sensation is mechanical. So like pressure, touch, right? So we have these types of senses. We have tactile senses, like touch, pressure, vibration, and tickle. So actually this one is a subgroup of this, right? Position sensation, also a subgroup of this one. Okay? Static positions and rate of movement. So at every moment we know the position of our limbs. Right? And if we move, we are aware of the movement of the body parts. Okay? So this is called position sensation. So both of these are mechanoreceptive senses. So let me correct it right now. So now they are doing, okay? So there are subgroups of this. We have thermoreceptive senses like cold and heat. We have nociceptive sense, which is pain that is caused by tissue damage, right? But we have another type of classification. So one type of classification is dividing the senses based on the stimulation, mechanical, thermal, or damage. Okay? Another type is like this, depending on the location of the receptor. The first type is exteroceptive. Extero means from outside, from the surface, right? So receptors are in the surface of the body, some receptors. Those are called exteroceptive sensation, like senses that are, so this type of sensation actually is responsible for detecting contact of the skin with the object, okay, and relies on the cutaneous mechanoreceptors, nociceptors and thermoreceptors. So when you touch something and then the sensation are coming from the skin, all of them are called exteroceptive. No matter if it's thermal or mechanical, everything, okay? But proprioceptive sensations are senses relating to the body, right? So they are related to the physical state of the body. So they provide information about the body and limb position and the movement of the limb. It relies on joints, receptors in the joints, muscle, and tendons. The third type is visceroceptive. Right? We didn't have this in the other classification, right? But here we have this visceroceptive. Receptors are in the internal organs. So we may feel, for example, our stomach which is full or empty, okay? Or we may have pain in some internal organs. So these sensations are visceroceptive. So remember this. Pain from internal organ is visceroceptive sensation. But pain from skin is exteroceptive. Right? And you have deep sensations from facial, muscles, and bone. So pain from broken bone is deep sensation. Right? So the type of the stimulation is the same. Depending on the location of the receptor, we may have exteroceptive, proprioceptive, visceroceptive, or deep sensation. Right? So these are different classifications. Today, we start with touch and we go on with other sensations that come from the skin and other ones. You can keep your questions, okay? And during the break or after the class, you can come to my office and I will talk about that. Let's go ahead a little and then we will get back here, okay? So, in this figure, you can see a piece of skin. You know that the skin has epidermis, dermis, and subcutaneous tissue, right? Okay. There are 6 different receptors in the skin responsible for tactile sensations. So the names are here: free nerve endings, hair receptors, Meissner corpuscle, Merkel disc, Ruffini endings, Pacinian corpuscle. You can see the figures here, okay? So, for example, here you have the free nerve ending. Okay, can you see that? Okay, this one. And these are Merkel discs, Meissner corpuscle, Ruffini ending, again free nerve ending. So free nerve ending can be located deep or superficially, right? But Meissner corpuscles are located superficially in the epidermis. I mean below the epidermis, right? And we have Pacinian corpuscles. So Pacinian corpuscle and Ruffini endings are located deep inside the skin, but Meissner, Merkel, and also free nerve endings are located superficially. So all of these 6 receptors are involved in touch, vibration, and pressure. Okay? Again, all of these are involved for touch, pressure, and vibration. But their contribution to these senses are not the same. For example, for touch, maybe Merkel disc is more important. For vibration, Meissner and Pacinian corpuscles are more important. Okay? So, now let's see these 6 receptors one by one. This is a free nerve ending. A nerve coming to the skin, then divides a lot of times. And at the tip of the nerve, we don't have anything. The axon terminal are exposed in the skin. Okay, you can see at the tip of the nerve axon, we don't have anything. Okay, it's bare. It's unmyelinated. Okay, so they are found everywhere in the skin and also many other tissues, and they can detect touch and pressure. So free nerve endings can detect touch and pressure. For example, in the cornea of the eye, the only type of receptor that is present is free nerve ending. And if you touch your cornea, you can feel it. Okay, you can feel the pressure. So this means free nerve endings are able to detect touch and pressure. The second type of receptor is Meissner corpuscle. You can see capsule-like structure. Okay, so we have the nerve, the axon. Yeah, it goes into the capsule. We have branches, and it's enclosed with a capsule-like structure. Okay, inside the capsule we have a lot of cells. Okay, but those cells are not actually neurons. They are just usual cells. They can carry the signal to the nerve ending, and the nerve ending is activated, and they can generate action potentials, and the action potentials can go through the axon to the DRG and to the spine. Right? So, Meissner corpuscles are capsules capsules that surround the entire sensory nerve. They are present in the non-hairy part of the skin. In the hairy part, we don't have Meissner corpuscle. Okay? So skin can be glabrous or non-hairy or hairy, right? Meissners are present only in the non-hairy part of the skin. And they are abundant in fingertips, lips, and nipple. Right? They are rapidly adaptive. So at the beginning of a stimulation, they fire very fast. Then, in a fraction of a second, they stop firing, or they decrease their firing actually very much. Okay? So they have great sensitivity. So they are very sensitive. They can detect light touch changes in the texture, okay, changes in the texture, movement of the object over the skin, and slow vibration. So, light touch, movement on the skin, changes in the texture, and slow vibration or low frequency vibration. Right? So the third type of receptor is hair receptor. Each hair and its basal nerve fiber can be considered as a receptor. So movement of the hair is felt. Right? So you can see that you have hair here, the follicle is located in the actually deeper layers of the skin. A free nerve ending comes the follicle and wraps around the follicle. Okay? So movement of the hair can activate the free nerve ending at the end of at the base of the hair. So it's rapidly adapting, and it can detect movement of the object on the surface of the skin and initial contact with the skin. So remember that in the non-hairy part, we have moisture. In the hairy part, we have hair receptor. Both of them can detect movement of this on the skin, movement of any object on the skin, and the initial contact with the skin. So, how many of the receptors we have seen? Three. And this one is 4. Merkel disc. Expanded epidermis. They are located in the lowest layer of the epidermis, so just beneath the epidermis. They are present in the fingertips and areas that we have a lot of moisture. Lips and nipples, right? But they are also present in the hairy part. Okay? But mostly in the non-hairy part. They are slowly adapted. So this one is slowly adapted. So when you have a stimulus, a constant stimulus, they start firing and they continue to fire as long as the stimulation is on. Right? There is a reduction in the firing. We call this adaptation. But adaptation is slow and small. Right? So they respond to steady pressure and punch. So steady pressure and steady punch. Right? They provide information about the object's quality, like the edges. Okay? So when you touch an object, you can feel the edge, the curves, the texture, if it's soft or coarse. Okay? If it's a piece of plastic or glass or wood, you can feel it. Okay? So all of these depend on Merkel discs, right? And they are also important for localization. So you know the location of the touch in your body. Localization, I mean precise localization depends on Merkel discs. So Merkel discs usually collect together in some organs or in some spots in the skin called egodome. Okay. So they collect together, so you can see that we have a lot of them together. All of them are innervated by a myelinated axon, okay? And they cause a protrusion of the skin out of the body, okay? So we call this egodome. Okay? The fifth one, I think, is Pacinian corpuscle.
Egodome.
Yeah, egodome. Collection of Merkel discs just beneath the epidermis. So this is the skin, right? Merkel discs connect together and generate a dome-like structure. Okay? All of these are connected by one axon. Okay, one axon that goes to the DRG, then to the spinal cord. Right? Pacinian corpuscle, we have seen this before. It's a myelinated axon with a teeth which is not myelinated. The teeth is surrounded by several layers of capsule. Inside the capsule we have fluid. So this one has a fluid. Meissner has some cells, right? So it's located deeper in the dermis or also in facial tissue. So it's rapidly adapting. You have seen that the most rapidly adapting receptor was this one, right? It adapts in some milliseconds actually. It can detect rapidly changing local pressure on the skin. So rapidly changing because it's rapidly adapting, right? And it can respond to deep pressure and fast vibration or high frequency vibration. So vibration like vibrating your cell phone in your pocket, right? Or feeling the vibration when you are in a car. Okay, so the car is on and it's going ahead, okay, and you're driving and you can feel the vibration. Or when you use something like a drill, or when you write something, okay, so any use of instruments actually involve actually vibration, okay? So vibration is necessary for having a proper feeling of the object. For example, a dentist that uses the drill during the treatment of a patient, okay, needs the vibration. Okay, so the feeling of the vibration helps the dentist or guides the dentist to work and do a good job on the teeth, okay, on a teeth that he or she cannot see this well, okay? So, Pacinian corpuscle and Meissner corpuscle are important for detection of vibration. Pacinian for fast vibration, Meissner for slow vibration. Remember these, okay? You should know them by heart. And Ruffinian D. It's a multi-branch encapsulated ending located in the deep layers of the skin and connective tissue. It's slowly adapting. Again, slowly adapting. So, Merkel disc and Ruffinian discs are slowly adapting. Pacinian corpuscle, Meissner corpuscle are rapidly adapting. Hair receptor are rapidly adapting. Free nerve endings have both types. Some of them are rapidly, others are slowly. Okay? So, Ruffinian discs are also present in joint capsules. So, they can detect rotation of the joint, any joint, fingers, elbow, everywhere in the body. Okay? So, let's summarize. We have 6 different receptors in the skin. All of them are responsible for touch, vibration, pressure. Right? Their contribution is different. Some of them are more important for touch, others are more important for vibration, for example. Right? And the other thing is that some of them are rapidly adapting, others are slowly adapting. You can see them here. Again, some superficially located receptors, Merkel and Meissner. 2 deeply locating receptors, Pacinian and Ruffinian discs, right? You can see the receptive field I told you before. The area of the skin which is covered by one receptor, by one neuron. Stimulation in the receptive field may activate the cell, the neuron. Stimulation outside the receptive field cannot activate the neuron, right? You can see that Meissner corpuscle and Merkel discs have a small receptive fields. So they are very precise. so they can locate the point of touch precisely. But Pacinian corpuscle and Ruffinian links that are located deep in the skin have large receptive fields. Right? So if you have 2 points that's applied to this receptor, so the receptive field is here, so this is the fingertip, okay? The receptive field of the receptor is like this, large. If you have a stimulation here and another stimulation here, the receptor cannot differentiate between these two, because both of them are inside the receptor. In order to differentiate between these two, they should happen in different receptive fields. Right? So there should be, for example, 2 receptive fields separated, stimulation in this one, and this one can go to the brain, and the brain can detect that, okay, they are separate. Okay? So, the receptive field is important for this. Now, let's see the response of these receptors to the stimulation. You have an increasing pressure, then a holding pressure, and then the end of the pressure. Right? Monster corpuscle responds like this. At the beginning of the stimulation, when the stimulation is going up, it has fast and rapid firing. Then it stops when the stimulation is constant. Again, when you release the pressure, there are a few action potentials, right? The same also happens for Pacinian corpuscle. During the stimulation or during the increase of the stimulation, you have some action potential. When it's constant, there is no action potential. At the release, you have again action potential. So, Monster corpuscle and Pacinian corpuscle signals the beginning and the end of the stimulation. But you can see the Merkel disc and Ruffinian link response. When you have a stimulation, at the beginning, they have higher firing rate. When the stimulation is constant, they continue to fire, but at a lower rate. When you release the pressure, they stop firing. Right? So, Merkel disc and Ruffinian discs that are slowly adapting receptors continue to fire as long as the stimulation is there. Right? So, these are important for the brain. The brain receives 2 types of information. And the brain knows the location of each of these receptors. Right? So based on this, the brain can feel precisely what's going on in the skin and also in the joints and muscles, okay? So, for detection of vibration, I told you, all of those 6 receptors are important, but 2 of them are more important, right? Pacinian for high frequency vibration. High frequency, I mean frequencies between 30 to 800 cycles per second. So when something is vibrating at this rate, the best type of receptor that can detect the vibration is Pacinian corpuscle. And the best frequency for Pacinian corpuscle is about 200 cycles per second. But low frequency vibration or slow vibration is detected mainly by mice. Between 2 to 80, and the mean frequency is, or the best frequency is 50 Hz. So you know the range of vibration of these cell phones. You know, if it's, for example, 30 vibration per second, which receptor is more important for mice, right? If something is vibrating very fast, chin. Very. Okay, I told you that we have 6 receptors for touch, vibration, pressure, and for each one tickle. Tickle is a tactile sensation, right? So we have 3 nerve endings for them. So we have some 3 nerve endings for touch, right? And some other free nerve endings for each. Some other free nerve endings for thecal, right? So remember these. You should memorize these, okay? They are very sensitive, rapidly adapting. So we have free nerve endings that are rapidly adapting. And they are found almost exclusively in the superficial layers of the skin. Transmit the signal through C fibers. The thecal is transmitted through each C fiber, right? Okay. I will talk about the type of fiber for those 6 receptors. Okay. Now let's go on with other receptors. Pain receptors. They are also free nerve, right? So we can say that for most of our sensation, we have free nerve. But for touch, pressure, and vibration, we have 5 other specific receptors, right? Okay, they are located superficially in the skin, and they are abundant in preosteum. You know preosteum?
No.
The covering of the bone. They are also abundant in arterial walls, and we have plenty of them in joint surfaces, and also in valves and tentorium. You know these.
Yes.
Covering of the brain, between the hemispheres and between the cerebrum and cerebellum, right? So we have a lot of these pain receptors in these tissues. So pain receptors are not uniformly distributed in the body. Some tissues have a lot of them, other tissues have small number of them. Okay? So some tissues are more sensitive to pain, some other tissues are less sensitive. For example, bone is very sensitive to pain because there are a lot of them. Arterial wall, valves and tentorium, and also the joint surface. So that's why if a bone breaks or you have fracture in a bone, it's very painful, right? Because there are a lot of these fibers. But there are a few of these receptors in other tissues, maybe. For example, in this intestine, pain nociceptors are scattered widely. Okay, so for example, every some centimeters, we may have, for example, 1 or 2 of these pain receptors. So that's why if you cut the intestine, it's not painful. So the surgeon, during the operation, may cut the intestine totally, and the patient may not feel it. Okay, because this sharp stimulation is not enough for activation of a lot of the pain receptors. Okay? So, pain receptors are non-adaptive. Remember that some receptors are rapidly adapting, you should know the names. Okay? Spacini and Weissner. Some others are slowly adapting, Raffini and Merkel. Okay? So, pain receptors are non-adaptive. They never adapt. So, if we have damage in the tissue and the damage is continuous, pain receptors start to fire and they go on, they keep generating action potential as long as the wound is there. Sometimes they become more sensitized, so they generate more action potential. So at first, for example, you may have a wound in your skin, you feel pain, but as time goes, okay, and the wound becomes chronic, the pain gets more and more. You will feel more pain, severe pain. Okay, we call this hyperalgesia. Hyperalgesia means increase in the sensitization of pain receptors. Okay, so over time you feel more and more pain. We call this hyperalgesia because the pain receptors become sensitized. Another condition is called allodynia. Okay, hyperalgesia. And allodynia are two syndromes that we have exaggerated pain. The first one happens because of the sensitization of the receptors, so a painful stimulation causes more pain after the sensitization. Allodynia is a condition that the pain receptors become sensitized and non-painful stimulation causes pain. Okay, examples. Like in the state of sunburn, okay, in the face, touching of the face causes pain. Touch shouldn't be painful. But when the tissue experiences allodynia, the touch causes pain. Sorry, I should answer this because they are taking the nervous system exam now. Okay, so what I was saying, allodynia. Okay, so the skin becomes sensitized, so touch causes pain. Touch is an innocuous stimulation, non-painful stimulation, but here it causes pain. We call this allodynia. Another example is arthritis rheumatoid. Arthritis rheumatoid. Okay? So when a patient with arthritis rheumatoid actually get up in the morning and come out of the bed, they feel severe pain in their knees by moving the knees. Movement shouldn't be painful, right? Movement is not a painful stimulation, but in this patient, it's actually painful. So this is another case of allodynia. Okay, so let's get back to our topic. Pain receptors are non-adaptive. In the general category, rapidly or slowly adapting, we call them slowly adaptive. Okay? Because I told you that we can divide all receptors into rapidly adapting or slowly adapting. Pain receptors are slowly adapting. But now we are correcting this, okay? Sometimes there is no adaptation. There is sensitization. So, you can see a pain sensory ending, okay? Okay, I told you that for every type of sensation, the cell that detects the sensation should have some mechanisms for converting the energy into receptor potential, right? I told you that for touch, for example, there are some mechanosensitive channels in the membrane that are activated by the stretch of the skin, okay? So when you press the skin, the mechanical deformation of the skin causes opening of some sodium channels, sodium go into the cell, then we have receptor potential. Receptor potential can cause action potential in the first node of Ranvier. Do you remember this? Okay, so this is for touch, for mechanical sensation. What about the pain? Okay, so for pain, we have some special ion channels in the membrane. Some of them are called TRP, transient receptor potential channels. Transient receptor potential channels, or TRP channels. So they are non-selective cation channels. When they are open, all cations go into the cell, sodium and calcium, and also maybe other ions that have positive charges. So they non-selectively pass the ions into the cell becomes depolarized, right? Other type of, so we may have, for example, TRPV1, TRPA1, so different types of these channels. V means vanilloid, a chemical, okay? A is an anchoring, for example. So TRPV1 is sensitive to intense heat, acids, chemicals such as capsaicin. Capsaicin is the active gradient of the pepper, hot So this one activates TRPV1. Acid also activates TRPV1. You can see that H plus activated TRPV1. Okay? And also capsaicin activates this one. And we have other receptors, right? For example, acid sensing ion channel, ASIC, is activated by pH. Cholinergic receptors, you know purines, ATP, GTP, these are purines, right? So we have inotropic receptors and G protein coupled receptors for ATP, P2X, P2T, okay? So they are present in the membrane of the nociceptor, like this. So for example, a mechanical damage to the tissue may cause damage of the cells. The cells release ATP. ATP binds to these channels on the nociceptors. They activate the channel. Cations go into the cell is activated. Right? We have also other receptors, TRPM, activated by cold, severe cold, I mean. Okay? Tyrosine receptor kinase A, TRKA. It's activated by nerve growth factor, NGF. So after damage to the tissue, these proteins are released. They can activate the nociceptors by way of, for example, so here we don't have TRK, but it should be also known here, okay? TRK is activated. So we have several cation channels by different names on the membrane of the nociceptors that are activated, and then they cause influx of ions into the cell. Then we have receptor potential. Receptor potential activates the cell by generating action. Okay? In the past, we didn't know these. In the past, I mean maybe 20 years ago. It's very new. And I think that 3 or 4 years ago, the scientists that discovered these won a Nobel Prize. Okay, Nobel Prize in medicine and physiology, because of the discovery of TRPV1 and other channels. Because in the past, we knew that, okay, damage to the tissue causes pain. How? We didn't know. Now we know that there are some channels involved in this process. And why they gave this Nobel Prize to the person? Because it can be the basis for future advances in the treatment of pain. Okay? So, let's go on. Type of nociceptors: mechanical, thermal, chemical, polymodal, silent. Okay? So, you should all of this in your mind. You have 6 receptors for touch, other things, tactile sensation, and we have pain receptors. But pain receptors are of different types. Some of them are very sensitive to mechanical stimulation. So severe pain, like pinching, causes pain. Right? So some of receptors only respond to mechanical stimulation. Severe cold and severe warmth, I mean hot and cold, may cause pain. They activate another type of receptor, thermal nociceptors, right? There are also some chemical nociceptors. They are not activated by these two, right? They can only be activated by chemicals. So chemicals are released after the tissue damage, right? Like bradykinin, histamine, acids, serotonin, potassium, proteolytic enzymes. All of these are released after damage to the tissue. They can activate some types of neurotransmitters, and these nociceptors, and they carry the signal to the brain. We have also polymodal receptors. Polymodal receptors can respond to all of these: thermal, mechanical, and chemical stimulation. So polymodal means some nociceptors that are sensitive to all of these, right? And they are very important for chronic pain. We have also silent nociceptors. They don't respond to any of these in the real sleep state. Okay, they are nociceptors, but they are inactive, they are silent. But in some situations, they become active. For example, when there is inflammation. Okay, inflammation in the tissue activates the silent receptors, and the patient feels more pain than normal. Okay, so 5 different categories of nociceptors are mechanical, thermal, chemical, polymodal, silent. Some textbooks actually combine these 2 together. Okay? They believe that some textbooks believe that chemical nociceptors and polymodal nociceptors are the same. Okay? But I divided them here into different categories. Now, I wanted to ask you if you have any questions. That I remember that you are not supposed to ask questions today, okay? Actually, I will give you some time for questions. Okay? So if you have any questions, write them on a piece of paper, okay? And then you can ask me. Now, so we have seen tactile receptors and pain receptors. Now, thermal receptors. Receptors that are sensitive to cold and warmth. Right? And we have also heat pain and cold pain receptors. We have seen this, right? We have seen them here. Thermal nociceptors. So, thermal nociceptors can detect pain, thermal type of pain. And they are also help understanding the temperature. Right? Here. So we have cold receptors and warm receptors in the skin. The number of cold receptors here is about 10 times more than the warm receptors. So we have more cold receptors than warm receptors. Right? So they are collected in cold spots in the skin. So they are grouped together in some spots called cold spots or warm spots. Okay? So the number of cold spots in the centimeter square of the skin is different. For example, in the lips, we have 15 to 25 cold spots. Right? In the fingertips, we have 3 to 5. And in the trunk, we have 1. So, which part of the skin is more sensitive to cold? Lips. Then, finger. Then there are other tissues, but the least one is trunk. Okay? And we have also warmth receptors in the skin that are 10 times lower in number than the cold receptors. And we have heat pain and cold pain receptors that are stimulated by extreme degrees of heat or cold. Now, let's see this figure. Okay. In the horizontal axis, you can see temperature, skin temperature. So skin temperature may vary from 5 degrees Celsius to 60 degrees Celsius, okay? And here you can see the number of action potential per second, 5 units. So you can see 4 different types of receptors here: cold receptors, warm receptors, heat pain, cold pain. So you can see the range of activity of the cold receptor. So if the skin temperature is about 7 degrees Celsius, they start to fire, right? Or let's say in normal situation, the skin temperature is about 37 degrees Celsius, right? The normal temperature of the body is 37. Okay, let's consider here. So at this temperature, which we call this indifferent, okay, you can see that cold receptors are active. So they generate 4 action potential per second, right? At the same time, warm receptors are also active. They also generate 4 action potential per second. So in the normal temperature of the body, both cold receptors and warm receptors are active, right? and they can send equal firing rate to the brain. Right? But if the temperature decreases, what happens? So for example, we change the temperature of the skin from 37 to 30. Okay, 7 degrees lower. So you can see that warmth receptors stop firing, but cold receptors send 6 action potential per second, increase their firing. So we feel cold. Right? Or it's better to say we feel cool. Okay? Then, when we decrease the temperature more, you can see that cold receptors are the only type of receptors that are active, and they generate the maximal firing rate. Okay? Then, when you decrease the temperature to about 10 degrees Celsius, you can see that cold receptors are minimally active, but cold pain receptors start to fire. Right? Now let's see the other extreme. When you increase the temperature, for example, more than 45, right? So at 45, warmth receptors are maximally active, and the heat pain receptors start to fire. So this signals the brain that damage is happening in the skin by temperature. It's very hot. So the brain starts feeling pain. Okay, from here. And then when the temperature goes up, the only type of receptor which is active is heat pain. All other receptors become inactive, right? So by the relative activity of these 4 types of receptors, the brain can detect the temperature of the body. Right? Sometimes the brain sees that, okay, all heat pain fibers are active, but the rest of the receptors are inactive, so this means it's very hot, okay, and there is a damage in the skin maybe, so it feels pain, okay? But in other conditions, for example, the brain sees that cold receptors and warm receptors are equally active, so it's indifferent, right? When cold receptors increase their firing and warm receptors decrease their firing, it means that the temperature is going down. Okay? So by this way, the brain has an actually understanding of the temperature of the body. So, for temperature, there are also some channels. So if you see your guided book, it says that by change of the temperature, the permeability of the membrane changes. And it says that maybe it happens by not ion channel, through the lipid bilayer of the membrane. Yeah, okay? But now we know that there are some channels also for temperature. TRPV channels are also important for temperature. So you can see that different TRP channels, transient receptor potential channels, are activated at different ranges of temperature. For example, from 25 down, okay, activity of the TRPM8 increases. TRPA increases, right? And we have also other channels. So each of them are active in a specific range of temperatures. And this is very important actually for me, because temperature also has channels. The change of temperature can open some channels in the body, protein channels, okay? So these are some new material I added to your slide. Try to not memorize specifically, but you should know the general names, okay? For example, TRP, very important, very important. I may ask you that, which channel is important for detection of temperature? Voltage-gated sodium channel, voltage-gated potassium channel, okay? Acetylcholine-dependent cation channel, transient receptor potential channel. Okay? So transient receptor potential channel. Which channel is both important for pain and temperature? So, and all of these options. Okay, again, TRP. TRPV1 was important for pain and also for temperature. Right? So, thermoreceptors are highly adaptive. I told you before. So, when temperature changes, these receptors start to fire very fast. When there is abrupt change in the temperature, there is also abrupt changes in the firing of these receptors. Okay, that's why when you go out of a cold room, at first you feel hot, okay, then you get used to that. This is because the adaptation of the receptor. And this happens for both cold receptors and warm receptors. So, when the temperature of the skin is actively falling, a person feels much colder than when the temperature remains cold at the same level. Okay, with constant temperature, the firing of the cold receptors decreases, right? Okay. Unit break? Yes?